So coronary artery disease is still the most common illness that we take care of, and it's still the most common cause of death worldwide. But what's most striking is that how late we tend to intervene on this and how early it actually begins.
By the time many patients enter the medical system, it's almost too late. They have symptoms or they've had a clinical event. For many of our patients, this is a heart attack or a stroke. And by then, the focus is really to take care of the event that's occurred and not really doing any prevention at that point. And so we want to spend some time in talking about how can we be one step ahead in this process.
Yeah, we want to talk about an approach that recognizes risk factors and takes action sooner so that we can have an opportunity to prevent this process from happening and change the course of our disease.
So this is a slide that I very frequently talk through with my patients. It shows the progression of plaque in a blood vessel. Early on, when you're young, you have a nice, healthy blood vessel. There's no plaque deposition. As you get older and if you have risk factors, you may have high cholesterol or blood sugar issues, and plaque will progressively develop. And this may start even in your 30s or your 40s. For some of our patients, even earlier than that. And as we go through, so there's some things you'll see. The last event on the end is the dreaded one, which is that if the plaque opens up, then blood products will accumulate at the site, and that's how you get a heart attack. But there are plaques in other stages. And the ones that you really hear about are like the large blockages where people are having chest pain or shortness of breath. But earlier than that, there's also other plaques that start developing, and patients may not have symptoms from those.
And by the time people feel symptoms, it's often too late, and you have to require procedures like stents or bypass surgery. And our conversation today is about shifting that focus from reactive care to proactive care, managing risk factors through a combination of lifestyle and medical interventions, which should start early, even in your 30s and 40s. So this is Life's Essential 8. You may have seen this logo throughout the whole health fair and through your roadmap that was provided. But what this is, it's the key factors that are used to prevent and treat coronary artery disease. It includes the things you would expect, not smoking, sleeping well, eating a healthy diet, managing your weight, exercising. But what it also includes is managing your other risk factors, such as elevated cholesterol, blood pressure, and diabetes. And what we know is that those risk factors are often out of your control. They come from genetic risk factors, they come from age and metabolic risk factors, and need to be treated along with managing a healthy lifestyle.
And I would say a very frequent question that we get, Raabia, and one that we actually already got several times when we were out at our table, is, I don't want to take medications. I really want to do this through lifestyle and diet. And I think, these issues that we're dealing with really are chronic illnesses, right? You have these when you're younger, they may get worse as you get older. And certainly the basis is always to do lifestyle changes, eating better, doing the Essential 8. But we know that we have medications also, or pharmacological treatments that can really reduce your risk, and especially if you can't get your risk factors controlled just through lifestyle, you can really meet your targets by using medication.
And what we know about a lot of these symptoms, diabetes, high blood pressure, cholesterol, a lot of it is genetic mediated, and no matter how healthy your lifestyle is, unless you use medications to control these risk factors, it doesn't come down. You're not causing your high cholesterol all of the time. You're not causing the diabetes, and you're not necessarily causing the high blood pressure. And no matter how healthy your lifestyle is, it can still you can still have these risk factors, and unfortunately does require medical therapy. And we're going to talk about using combinations of lifestyle with medications to really prevent and treat coronary artery disease. So these are the factors, these are the goals and the targets on the left side that we want to treat. We want to bring blood pressure down below 120/80. We want to bring cholesterol down. targeting LDL below 100 in the average person, below 70 in people at high risk, and people who've already had heart events, we really target below 55. And these are not really physiologically possible in most individuals. The body produces cholesterol. A lot of people think that cholesterol is something you're taking in. Yes, if you eat a horrible diet, your cholesterol will go up. But even with eating a vegan, low-fat diet, people's cholesterols can still be high, and I'm sure you guys have seen this. So it's important to take medications to treat these cholesterols because that is one of the biggest risk factors for heart disease. And along with treating fasting glucose, diabetes, we want to target low blood sugars, and diabetes is not always caused by obesity and eating a lot of sugar. A lot of times it runs in families, it can be genetic and metabolic related, and we need to treat that.
You know, I joke with my parents that I'm going to go through their risk factors like they went through my report card when I was younger. So
that's the way to think about it. That's what I do with my patients when they come see me.
Yeah, so I give them a hard time about their numbers. So, you know, we know that these are kind of like the basic things when you go to your doctor's office, that they'll take a lot of these metrics. There are additional risk factors that you can test for. You might have heard of Lp(a) or lipoprotein A, apolipoprotein B, and high sensitivity CRP. If your testing comes back abnormal, that may give you, may re-stratify you into a different category of risk. We also know that additional risk factors like having an early family history of coronary disease or heart attacks, women who have preeclampsia during birth or gestational diabetes during birth, and then also women who go into menopause earlier, all have a higher risk of having cardiovascular disease.
Mm-hmm. Also, certain populations where you're from really does matter. The South Asian population has a much higher risk of heart disease just based on where they come from geographically. So the way I think about all of these things is when I see a patient and we are looking at how do we prevent you from having heart disease, we go through these numbers. We get these blood tests, and then we use that data to decide what's your risk and how are we going to treat you appropriately to prevent heart disease in the future. So when we talk about glucose and obesity management, those were on the Life's Essential 8. Those are very important. And we know that diabetes is such a significant precursor and risk factor for coronary artery disease. And now we have these newer medications that really are heart medications and diabetes medications and have really changed how we think about treating cardiometabolic risk. So specifically the GLP-1 agonists that most of you have heard of, Ozempic, Mounjaro, Wegovy, Zepbound, these are drugs that got a lot of attention for bringing weight down, and they're viewed as cosmetic medications, but they really are cardiovascular medications.
Yeah, I think everyone kind of knows them as weight loss medications, but in some of the original studies, we know that even though it was looking at glucose control, a good population of the patients did really well in terms of the cardiovascular risk. So we know that these medications are good for the heart as well, and I think that's what's made at least me more comfortable with using them in my day-to-day practice. We know that these medications can improve your insulin sensitivity. They obviously, as a great side benefit, help you lose weight. They also can help with, for us really, it's reducing your cardiovascular events. And there are, I think, clear clinical trials that have shown really strong benefit. So I think, these benefits really have been seen both with non-diabetics and diabetics. So you will see that many patients without diabetes are on these medicines as well.
There's also a newer class of medications, SGLT2 inhibitors, which have been shown to have cardiovascular benefit as well. These are mostly in heart failure and preventing heart failure hospitalizations, preventing people dying from heart failure, and people with diabetes should all pretty much be on SGLT2 inhibitors to prevent that side effect in the future. So we think about these drugs as combined diabetes and heart medications that really should be part of the conversation when we talk about preventing heart disease.
So I think we know very clearly that LDL reduction reduces your risk of heart disease and heart attacks. And that has actually been a very frequent and controversial question that's been brought to me in my office. But I think we have a lot of data to support that. So it is surprising to me that it's controversial.
Yeah. And so the slide on the left pretty much shows what we're talking about. So high LDLs throughout life eventually can lead to significant plaque buildup. And that's why when we talk about heart disease, we often talk about cholesterol. And I think the cholesterol medications are not always put together as plaque-lowering medications. But that's how I think about it. Because if you follow a lifelong healthy lifestyle, you target that low cholesterol early on, you never have enough circulating cholesterol to lead to that clinically significant heart disease. That's where we talk about that conversation about starting early. Along with lifestyle, keeping your cholesterol as low as possible prevents you from developing heart disease.
So there's a few classes of medications that we commonly use to lower cholesterol. Statins are probably the most popular. They are the easiest to take. They're the cheapest. And probably the most understood medications out of our regimen. Might have also heard of PCSK9 inhibitors, which are injectable cholesterol medications. You take it every 2 weeks. Ezetimibe, which is an oral medication that really is good for LDL lowering to some degree. It doesn't have as many benefits for plaque prevention. And bempedoic acid, also good for LDL lowering. Some data for plaque reduction, but not as strong as statins or PCSK9 inhibitors.
And I think statins really do get a bad reputation. We have gotten that question several times today. And people often come to us immediately saying, well, I have plaque, but I can't take a statin, or I don't want to take a statin. And I think we all get a little bit, triggered by that as cardiologists when we know how strong the data is regarding statins. And I think what gets misunderstood about statins is they're not just about cholesterol. They really have additional benefits to the blood vessels. They prevent plaque buildup. They prevent the formation of plaque, but they also have an anti-inflammatory benefit and prevent that plaque rupture we talked about at the beginning, where the plaque can rupture through the wall, cause a clot, and lead to a heart attack. And the statins have a very significant role in that, along with PCSK9 inhibitors that Cindy mentioned. And PCSK9 inhibitors and statins are probably the best medication we have in terms of plaque prevention, plaque progression, but also potentially plaque regression and pulling that plaque out. And we really should be individualizing how we treat cholesterol based on people's risk factors and based on how much, if they already have plaque, we'll talk about calcium scoring and all of that and how that plays a role. But it really, when we talk about prevention, a lot of what we talk about and what we recommend to patients is treating the cholesterol.
And I think another point that's a little confusing is that you can certainly, there are some plaques that are kind of the scary plaques with the thin tops, and statins can really convert those thin top plaques into more stable plaque and more calcified plaque. That sounds confusing, but you want your plaque to kind of be stuck to the wall and gunked on. You don't want it to be loose and able to open up. So that's an important point. Well, we already started addressing the elephant in the room, which is that we would like to talk about some of the myths about statins or misconceptions about statins. And I think as cardiologists, we have a lot of experience with this because we get sent the most difficult cases, people that are truly statin intolerant, and there is room for that, but we will kind of go through some of these ideas. So statins causing dementia. True or false? Yeah.
False. This is a question we get a lot. People are really worried about statins leading to brain fog and dementia. And what we know is that statins don't cause dementia. Statins may be associated with dementia only because as people get older, they have high cholesterol, they get put on cholesterol medicine, And as people get older, their memory gets a little bit worse. There have been a lot of people trying to link these two, and all the studies looking at that are that there's no causation, and if anything, statin users have less risk of dementia. So I often equate this to my patients when we have this conversation to the anti-vaccine conversation. And when I say that, I think most of us understand the validity of these well-established vaccines and that they don't cause some of the things that people say they do. And I think there's a lot of people out there who try to make statins sound worse than they are. And so we really have to break down these myths and work on that.
I think another common, misconception is that that statins cause muscle damage. And I would say definitely the most common side effect that we know is muscle pain, maybe joint pain. And that is definitely and certainly a side effect that we notice. And usually I just work with my patients on getting them either to the right dose of a statin that works for them, that they tolerate, because I know about a lot of the benefits. And then I can add medication to it to get them to their cholesterol goal.
Yeah, and I think the muscle conversation started with the earlier statins. So atorvastatin, simvastatin, some of our older statins definitely cause more muscle aches. Newer statins, the one I use the most is rosuvastatin. It's metabolized a little bit differently and tends to be the best tolerated, and a low dose actually brings the cholesterol down significantly. And we also know that some of these side effects are dose dependent. So if you don't tolerate a high dose, we can tolerate a very small dose, even half a pill 3 times a week, and we see a significant benefit in that. So like Cindy said, I always work with my patients. I say, well, let's try it once a week and let's build up to it and see if you tolerate it. I think never trying it because of a fear of risk is very common. And I think trying it once, having a side effect, and then never trying it again or never trying to find the right dose that works for you is something we see often. And because there's such a strong benefit, we really do work with our patients to try to get it on. But there definitely are some people who don't tolerate it because of that muscle side effect, and that's where some of those other drugs we mentioned are useful.
In terms of supplements, I would say, red yeast rice has probably some of the same properties because it is basically a statin, right? It's a natural statin. But in terms of the other supplements, I don't think they have really as much power in lowering as the statins do. Yeah. And I don't, in that way, like the potency really is associated with the degree of prevention you're gonna get overall.
And I think supplements, often people are more willing to take a supplement than they are, a medication. And I think the supplement conversation happens a lot. But what people are not understanding sometimes is supplements don't go through the same rigorous FDA process and control process of our drug development. And supplements can, be mixed in with other things, have other side effects. And it's very clear that supplements, even omega-3 fatty acid, has not been shown to prevent heart disease. And really, there's no supplements that are beneficial in heart disease prevention.
And then the last is just that, I've been told I directly benefit from, prescribing a statin. I make money from it. The pharmaceutical industry makes money from it. Maybe, I wish, because I prescribe it so often, but no, I don't. So, I think that's a big misconception.
I think that's because we push it so hard. You can hear us having this conversation. And the reason we as cardiologists talk about statins, and it's always part of the conversation, is not because we benefit from it in any way, but because we understand the data and know how strongly these medications prevent heart disease, and really that any long-term, any risk of the statins is much, much lower than the long-term benefit of being on a statin. So
we're going to shift over to just discussing. We talked about medication, lifestyle interventions. What are ways that we have in medicine to kind of re-stratify your risk? We talked about those blood markers, but there are actually imaging tests that can also help you kind of determine your risk. And Raabia's going to talk about calcium scoring a little bit. This has been a big way for people to learn something more about themselves aside from the traditional stress testing.
Yeah, and I think it's really allowed us to individualize and target people's own strategy for prevention based on what your arteries look like. So we usually start with the calcium score. Already many people have come up to me and asked, well, my cholesterol's high, what should I do? I usually ask them what their calcium score is, and if they have I recommend doing calcium scoring as a first line to determine how we're gonna target your preventative strategy. And essentially, a coronary calcium score, CT, which is here on the left side, is a non-contrast, low-radiation CT scan that's telling us if there is plaque in the arteries or no plaque, and risk stratifies you into a category of mild, moderate, or severe. And then we use that information to decide how we treat the cholesterol, how aggressive we need to be. If the calcium score is 0, we often say, okay, you're at less risk, depending on your age. If it's 0 at 40, I say, great, but still work on all these things. If your calcium score is 0, but your LDL cholesterol is 200, I usually say, well, let's keep it 0, and let's treat the cholesterol now before it turns into having a calcium score of 1,500, which is what we see at the bottom. One thing that commonly gets misunderstood here, though, is if the calcium score is high, people think they already have heart disease and need a stent. And that's not true. A lot of times, this doesn't give us that level of data. This gives us information that there is the presence of plaque, but doesn't tell us where that plaque's located, whether it's affecting the blood flow, and what is actually going on inside the artery. So it's really a screening test.
Yes. And probably the most helpful population this is used for is people that are middle-aged, so men probably in their 40s to 50s, women in their 50s to 60s. Certainly, I've used the calcium score in age ranges outside of that, and it's still helpful, but that's kind of the area that would be kind of the most appropriate because you have time to intervene and do prevention. What we've also been using very frequently now is something called coronary CT angiography, which is essentially one step further in doing a calcium score. So you will map out the arteries completely when you do this. And so there's 2 examples here. One is the left anterior descending artery and then the right coronary artery. These are reconstructed images. And you can see that we can, in this way, tell the patient exactly how much plaque, both calcified, which is the white specks that you see, and then non-calcified plaque as well. On our next slide, we just show that. So when I look at these things, I read them, I look at them by eyeball, and I estimate how much stenosis or blockage there is. On the left, you see CT-FFR, or fractional flow reserve. It's a type of artificial intelligence software that's applied to these to CTA, and that will kind of reaffirm what the doctor is thinking. And so this example just shows a significant blockage in the main artery. I guess an extra step is that we're doing something called plaque analysis as well, which is when you take that same CT angio picture, and you can actually, using same thing, artificial intelligence, you can actually assess the degree of plaque and actually break it down into percentages of non-calcified, calcified, and also low attenuation plaque. And different types of plaque have different risk. If the higher amount of, we're more scared of the non-calcified plaque, and then especially the low attenuation plaque. So we can tell people almost the composition of their coronary arteries, the plaque composition completely.
Mm-hmm. So I think about this as precision prevention. We're no longer just treating these numbers that we mentioned in isolation. We're treating the actual disease. And when we make recommendations for our patients, a lot of times we have this level of information to decide how we're going to prevent that plaque from getting worse, how we're going to prevent them from having a heart attack from that plaque, and how we're going to potentially follow them throughout their lifestyle and monitor for the development of symptoms. And I think the key, this really has changed how we manage things. This gives us the level of data we used to only be able to get invasively, through an invasive procedure, which has its own risks. And now this is a very low-risk test. It does involve radiation. It does involve IV contrast, which can have its own issues. But it is something that gives us such a level of information and a level that we can precisely manage people's risk factors and, diagnose disease before it's actually caused a heart attack. If people start to have symptoms, vague symptoms, we don't know what to do. This gives us the exact information. And oftentimes we go in with a coronary angiogram and we know exactly what we're going for. If someone, like in this case, this LAD blockage, we know exactly where that blockage is and what we're going to treat. And for our interventional colleagues, they can even, decide on the size of their stent, and they can get a lot of information that we used to only have from doing this invasive test.
Yeah, so I think, doing prevention helps us, keep your heart healthy, keep your heart well, prevent heart attacks, prevent strokes. And we're hoping that this talk inspired that in all of you today. Any questions?
Thank you so much. You guys covered so many wonderful topics, the hot topics that people are wondering about, and you are answering these questions daily, but we really appreciate you coming and delivering this message to the audience here. We do have just a couple questions.
Sure.
Most of the ones that we received, I think you answered. If you didn't get your question answered, we look at them and we'll send out a FAQ after the event, but here's two. Multivitamins have 100% calcium requirement. Is there any risk associated with taking daily supplements with calcium in elderly folks that are over 80 years old?
It's a common question we get, and I think it's a little bit confusing because we use the term calcium when we talk about calcium scoring, but that's not the same as the calcium we consume, the calcium we talk about in our bones. It's really talking about plaque. So when we say calcium, it just means it's hardened, calcified plaque, but it's not the calcium you consume. So we're not worried that the calcium supplement, if taken in appropriate doses, is causing any impact to the heart arteries themselves. So I think that's a very common confusion.
Okay, that's good. So what is the method of action that GLP-1 antagonists are able to reduce the probability of all cardiovascular disease? So what's the method of action? I don't know.
That's a really
You're not a pharmacist,
good
but yeah.
Well, I think it's probably not fully understood what the mechanism of action is, but I think the idea is that it's having anti-inflammatory benefits, and we know that that inflammation is what leads to plaque buildup. And so if we treat that inflammation, it helps improve it. But what's interesting is actually we don't know the quite mechanism of action. It was just noticed that when people got treated with these medications, they had less heart attacks, and they had less strokes, they had less events. And so it's an association, but I would say we don't quite know the exact mechanism of action.
Yeah.
Okay.
I mean, it was a very powerful study when it first came out, and I think that was everyone's question. I don't think there's been a lot of progress since then,
And
in
it
terms
is
of the
beyond
etiology.
beyond the glucose lowering effect, or the weight loss benefit. So it's not, you can't replicate it just by losing a lot of weight or getting the glucose down in other
so
ways.
it's an addition. Okay,
Yeah.
wow, okay. Well, that's great. Well, thank you so much, both of you. Appreciate
All
you.
right, thank you.
Yeah.